In this Medicine in Minutes, we discuss the vitamin K antagonists, also named VKAs. These are warfarin, acinocumarol, and fenprocommon. Vitamin K is normally consumed in our daily diet and is abundant in green vegetable leaves. Vitamin K is a fat-soluble coenzyme. This means that it's an enzyme that helps other enzymes in their activity and functions. It is important in formation of several procoagulant factors, like factor 2, 7, 9, and 10. These factors are necessary for the stimulation of coagulation. To a lesser extent, vitamin K is also involved in the activation of anticoagulant factors, like protein C and protein S. Here you can see an overview of the intrinsic and extrinsic coagulation pathways. VKAs target the enzyme vitamin K epoxide reductase. By inhibiting this enzyme, the production of vitamin K1 for the coagulation factors is decreased. As you can see, the synthesis of coagulation factors 2, 7, 9, and 10 are vitamin K dependent. VKAs reduce synthesis of these procoagulation factors, and in that way, the coagulation cascade is inhibited. VKAs indirectly contribute to anticoagulation, unlike the DOACs, which are called direct oral anticoagulants for a reason. Because VKAs initially target vitamin K and not the procoagulants themselves, this has several consequences. Firstly, they won't affect the function of existing coagulation factors. They only reduce the synthesis of new coagulation factors. Therefore, VKAs are indicated for the prevention and treatment of thromboembolic complications. However, the optimal desired effect is achieved after some 2-3 days. So in case of acute indication for anticoagulant therapy, like life-threatening thromboembolism, heparin and other direct oral anticoagulant drugs should be considered. Anticoagulant effects of VKAs can be influenced by different diseases, co-medications, diet, or herbal medicines, and changed absorption. Therefore, adequate dose adjustment of VKAs is needed to prevent undertreatment and complications. The effect of VKAs can be evaluated with the prothrombin time, which is normally around 12 seconds, and represents the extrinsic and the common coagulation pathways. For dose adjustments of the VKAs in the clinical practice, the International Normalized Ratio, or INR, is used. The INR is a ratio of the patient's prothrombin time against the mean prothrombin time of the general population, which can be seen as the control prothrombin time. So what is the difference exactly between the VKAs? The important differences are in the half-lives. Acinocumarol has a half-life of about 8 to 11 hours, whereas fenprocommon has a half-life of 116 hours. Warfarin sits in the middle with 21 to 89 hours. The duration of anticoagulant effect of acinocumarol is so much shorter compared to fenprocommon, which can be used to your advantage. The short half-life of acinocumarol makes it possible to interrupt the treatment and its effects quickly. If a patient is planned for surgery, for example, acinocumarol can be interrupted a couple days before the surgery and the INR normalizes on short term, whereas treatment with fenprocommon results in a more stable INR over a longer time. When an excessive INR is measured above the therapeutic range without any signs of bleeding, the VKA should be reduced in dosage or discontinued until the therapeutic INR range is re-established. In case of an excessive INR accompanied with bleeding complications, VKA should be stopped altogether. However, when there is not enough, administration of vitamin K may be necessary. Vitamin K, also called vitaminarion, can be administered in case of a minor bleeding. Vitaminarion can be administered orally or intravenously. It is effective after a couple of hours because the coagulation factors still need to be synthesized in the liver first. In the case of a major bleeding, or when direct correction of the coagulation pathways is required, prothrombin complex can be administered. Prothrombin complex is an intravenous solution that contains coagulation factors 2, 7, 9, and 10, which were the antagonist factors by VKAs. When you monitor for VKAs effects or side effects, bleeding is of course the most important thing to be mindful of. Although the INR is a good measure of the bleeding risk, this is not something that gets measured constantly. For some stable patients, that can be up to 6 weeks, for example, in between measurements. Therefore, looking at clinical symptoms and vital signs are just as important. For example, bruising. Slight knocks can cause bruising a lot faster when taking VKAs, so try to keep risk of bruising to a minimum for the patient. For example, removing furniture with hard edges or helping them up from the seat when standing up. In the case a patient gets a knock and starts bleeding, minor bleedings can be treated with a small gauze or a clean cloth over the wound. Injuries to the head, however, can lead to a dangerous internal bleeding. Inform a physician if this happens and closely monitor the patient's breathing, signs of weaknesses, dizziness, and pains in other areas. Lastly, be mindful of the patient's diet. As said, vitamin K is a natural component of a green, leafy vegetable, so try to keep a large amount of such foods to a minimum. Also avoid things as alcohol and nicotine use, as this can also lead to more substantial bleeding. When a VKA needs to be discontinued because there is no indication or for any other reason, VKAs can be ceased directly without the need for gradual dose reduction. For acinocumarol, it usually takes about 2 to 3 days before the INR is normalized, and for warfarin and fenprocommon, it can take a little longer. So it is important to take the half-life effect of the VKAs into account when a switch to a different drug, for example anticoagulants, is desired. For example, when a VKA is switched to a direct oral anticoagulant, like the DOAC should be administered only if the INR is below 2 to reduce the risk of bleeding, because the effect can still linger on. On the other hand, if a DOAC is switched to a VKA, then the DOAC should be ceased until adequate INR of more than 2 is achieved, because it takes longer for the VKA to be optimally effective. In summary, VKAs are indirect anticoagulant drugs that inhibit the synthesis of vitamin K-dependent procoagulant factors 2, 7, 9, and 10. They prolong prothrombin time, and their dosage is adjusted based on the INR. There are multiple VKAs available, which are all different based on their pharmacokinetic profile, which can be advantageous in different scenarios. In cases of bleeding due to excessive INR, vitamin or prothrombin complex can be administered.